So today we have Dr. Tensor, who is going to be talking about his recent paper, Accelerating Cardiac DTI with Deep Learning-Based Tensor Denoising and Breath Hold Reduction, a step towards improved efficiency and clinical feasibility. So this our speaker in the paper was selected by Matthias, who normally would be hosting today, but it sounds like he is on a delayed plane, so he is not able to make it, at least right now. So I'm going to be hosting instead. I'm Nicole Cyberlick from the University of Michigan, and I'm also very excited to hear about cardiac DTI, because I think this is a topic that has become more and more interesting over time. DTI is used in so many other parts of the body, and it could provide information that is really unique, because diffusion weighted images and maps are they really kind of give orthogonal information to the other kinds of weighted images that we collect. And so being able to collect this whole new contrast in the heart really opens up new avenues to see all sorts of different things that we aren't really able to evaluate right now because of the difficulty of combining cardiac imaging with DTI. So it's perfect paper and very timely, and I'm going to hand it over to Dr. Tensor then to explain the paper. You are our only presenter today, so you have a little bit more time than we normally would have. So I'd ask you to explain your paper. Maybe take 15 or 20 minutes, and then we can open it up to questions from the group. So please take it away.
Thank you very much for the introduction. Let me share the window. Okay, I hope you can see it.
Yep, perfect.
Yeah, again, thank you for the introduction. I had prepared a shorter presentation, but I guess we can go through questions, and then later on, if anyone has any specific request, we can go through that specifically.
Perfect.
So cardiac DTI is a unique modality because it lets us probe the cardiac microstructure non-invasively. Previous work has shown that it has the potential for improving diagnosis in myocardial infarction and various cardiomyopathies, like hypertrophic or dilated cardiomyopathy. The main limitation of cardiac DTI at the moment arises from the fact that it's a low SNR technique inherently. To get acceptable image quality, we need around 10 repetitions per slice, which means around 10 minutes or 10 breath hold per slice at one cardiac phase, which is obviously not feasible clinically. Our group has already worked on this problem before. In previous work by Ferreira and colleagues, we showed you can use a UNet to compute diffusion tensors directly from reduced repetition data. And this was a very good step towards accelerating cardiac DTI. In this paper, we take it even further by shifting from a tensor computation problem, like the one in Ferreira et al., to a direct denoising problem in tensor space. We combine this with several architectural improvements and a data augmentation strategy that better captures realistic acquisition variations. We tested this on 744 datasets, covering a wide range of pathologies, and crucially, our method succeeds in cases where previous algorithms completely failed, particularly in patients with abnormal cardiac anatomy. I have here some details about the population we use for this study. And then I would like to move to the results first, and then we can go through the methods later if there are any questions about that. So zoom in a little bit more. So this is what it looks like in practice. Looking at figure 2 here, you can see maps from full repetition data, which is what we would normally acquire. Then classical linear least square approximation for the computation of the tensor. The UNet from Ferreira et al. That I mentioned earlier, and our methods specifically here. This is all shown at 3 breath holds, starting from 10, so an acceleration of over 3. The key thing to notice here is the error maps on the right. So our method here shows substantially lower errors, particularly for helix angle maps and sheetlet angle, with up to 20% reduction in errors compared to UNet baseline from here. I would also want to move on to two specific clinical validation cases. So for the clinical validation, we looked at myocardial infarction cases mostly. Here you can see examples of a myocardial infarction patient, where the red arrows show infarcted tissues and blue arrows show remote myocardium. All the three methods that we show here maintain the numerical difference in MD between infarcted and remote regions, which is statistically significantly different. However, when we look at the one breath hold case, we start losing visual quality and confidence. So we believe, and for the rest of the paper, we mostly show three breath hold cases, three breath hold images, because we believe this is the right trade-off to get a meaningful scan time reduction while maintaining diagnostic accuracy. The second clinical validation that I wanted to show is so this is a situs inversus totalis patient where the heart is mirror image. This means that the helical pattern is reversed to what you would normally expect. So we see positive angles here on the outer edge of the left ventricle, where we would normally see negative angles and vice versa. These angle maps look very different from what we normally see in normal anatomy. And what happens here is that the unit completely fails at calculating tensors from this case, because it's never seen this pattern before, essentially, and it produces results that are anatomically impossible. In contrast, here on the right, our method preserves the reverse pattern perfectly, even though we had 0 seed cases in the training data. This proves that the model learned general principles useful to denoise arbitrary cardiac microstructure, rather than just memorizing normal healthy anatomy. So this is most of what I wanted to show very briefly. So in summary, what we've shown in this paper is that cardiac DTI cardiac DTI with 3 to 5 breath holds while maintaining diagnostic accuracy across diverse pathologies and with very major anatomical variations. This speed up factor of up to 4 represents an important step towards making cardiac DTI fit for clinical use, though, of course, further validation is needed before routine clinical implementation.
Awesome. Thank you so much for keeping in time. Usually we have a hard time with our authors.
The one time where more time would have been allowed.
That's great. That's totally great. Perhaps you could use a little bit of the time to describe some of the methods that you used. So
yes,
how the model was developed.
Yeah, so we can go back to the method section just to have a quick overview over that. So we pick, okay, so I think there are a few things that we need to go through. The first one is the what the input and outputs are, essentially. So in previous work, we have seen 2 major ways of dealing with the problem of reduced repetition in general, let's say DTI. One main approach is denoising images prior to tensor computation. This has been done by some work before. The other main approach that we've seen in Ferreira's work is instead computer denoising tensors from reduced repetition image data. Here we try a different approach that again frames the problem as a pure denoising problems. This has the advantage of relying on the whole denoising literature, denoising models, denoising architecture that already exist, that have been studied for other tasks. What we do essentially is that we frame the problem as a tensor space denoising problem. So it's a standard denoising image to image, except that instead of it being image, it's tensor components. From the specific modeling architecture, we use a vision transformer-based model with an ensemble strategy and a GAN, so a generative adversarial network framework. The other thing that I think is worth mentioning is the data augmentation that gives us quite a big advantage over previous methods. So a lot of previous methods use the data available quite naively, either by taking only the first n repetitions, or that's what's mostly done, or by taking a random subsample, but that's not quite accurate because in a real acquisition, patients are in the machine and require n of them in a row, essentially, and n acquisitions in a row, not n random ones, and there is some drift that might happen during the acquisition that is important for the modeling. So the specific data augmentation we use takes chunks of n repetitions. So yes, this is the main overall novelty, I would say, from the methodological perspective.
And maybe I can just start by asking another question about how the actual acquisition worked. So when you have the 1 breath holds versus the 10 breath holds, so are those different acquisitions, or is one a subset of the other? Or the 3 breath holds, for instance?
No, it's one of the subset of the other. So when we say 1 versus 3 or 3 versus, sorry, 10 versus 1 or 3 versus 10, then the 3 is a subset of those same 10.
Got it. Okay. So have you looked to see, for instance, if you have, 10 breath holds worth of data, and you reconstruct, 3 of those, you put 3 of the breath holds together to reconstruct a DTI map, I guess, a set of maps, and then you take a different 3 and a different 3. Have you looked to see how similar those are, especially compared to the whole 10?
Yeah.
Because I mean, right now, like, it seems like you could end up with different maps depending on like exactly where the breath hold positioning is, or if there's like just any differences in your actual slice that you're collecting.
So we looked at this for a very, very early draft of this paper, and I don't remember all of it perfectly. What I do remember is that we looked at what the error compared to the 10 breath hold acquisition is, and I remember that for most of the maps that was all the errors were very similar. So maybe they might look slightly different, but they all in a way that looks like noise, unstructured.
Got it. So there was not a difference, for instance, between like the first 3 breath holds and the last 3 breath holds, or something.
So that was our assumption as well, and that's why we did the study to begin with, because we thought that maybe the patient was, less tired, better at breath holding at the start, or maybe later on it would be better because they learn how to breath hold, they learn the timing, they learn how to do it properly. We didn't see any of that. I mean, not from an error perspective. I'm sure there is some difference that we didn't see, but if you look at the error compared to the 10 breath hold acquisition, then there wasn't any.
Okay, got it. Yeah, I think it's a good study to have thought about. I'm sorry I didn't make it into the paper.
For different reasons.
Happens.
Maybe we
Yeah.
didn't look at the right thing, and it wasn't a good fit for the narrative of the paper.
All good.
It was an interesting study.
Awesome. Okay, I've been dominating questions so far, so the paper is definitely open for questions. If anyone has a question, you can feel free to drop it into the chat, or unmute yourself and ask your question or raise your hand, however you'd like to.
So this Matthias, I'm sorry, I'm late. Just touched down in Stockholm, so I missed a lot of the party. But of course, an obvious question also is, because I know that always we have clinicians on the call. So how far do you think this would be from kind of a routine application on several systems integrated into maybe inline solutions or other solutions?
Okay, so I think there are some obvious limitations that need to be addressed before this makes it into clinical practice. Some of them are quite obvious from the paper, I would say. So for example, we have very few cases of some pathologies. For example, okay, so one thing that needs to be said, and we show this in table, in a table, I'm not going to go through the whole paper, is that the model has higher errors for pathological, for patients compared to healthy volunteers. This is made better by having more data for each pathology, but for some pathologies we only have very little data. For hypertrophic, for dilated cardiomyopathy we have 4 cases. For Marfan syndrome we have 7 cases, and this is severely underrepresented. So we will need more data from all pathologies to make it more reliable in those cases. And this is a major limitation if this needs to be used mostly on patients. Another maybe minor limitation is that it's not fully manual yet, fully automatic yet. So it still needs a lot of manual intervention to delineate the left ventricle. There are also some modeling issues. For example, that everything here starts from a linearly sparse method, and there are better methods to start with. So we would need to verify exactly how the model works by starting with a better tensor approximation.
Yes.
Yeah. Oh, sorry.
Yeah.
The other main limitation is that this was mostly done on STEAM data. We do have a table in the appendix showing the performance on spin echo data, but this needs to be all redone on spin echo data. Like this works on spin echo, but it needs to be retrained and revalidated on spin echo data.
Yeah. Okay. So there are clearly some additional hurdles to be taken. And I don't know whether Sonia is also on the call, because I know I discussed with her before the clinical implications of this. So where can DTI make a substantial difference when compared with strain other functional data? And we know that in certain pathologies like hypertrophic cardiomyopathy, the direction of fibers is very important, but so far some critics say that the added value for the huge effort that is needed has to be still demonstrated. So do you have thoughts on that?
I'm not a clinical person, so I'm not sure exactly how to answer
That's
that.
okay.
I do know the team is working a lot with cardiologists and clinicians on this specifically, on when we can take advantage of DTI the most, and when it's significantly better than other methods. But I'm not sure about the specifics.
Yeah. Okay. So Nicole, that was it from my side.
So I did want to ask a question. So this is 3 breath holds for one slice. So if you're using this technique clinically, are you using it to evaluate something where one slice would be enough data, or do you need to cover the entire heart, or kind of how would the DTI be incorporated into the overall clinical protocol? I guess is 3 breath holds fast enough now, or does it still need to be faster in order to be set out for routine use?
So the answer I think depends a lot on what pathologies have been used for. There are a lot of other people in the call that work in my team that know this better than me, so please correct me if I'm wrong. But for some pathology, one or few slices at one cardiac phase are enough, and in that case, we're able to do a very fast acquisition, for which maybe 3 breath hold would be enough. For some other pathology, we definitely need multiple cardiac phases and multiple slices. And in that case, even with 3 breath holds, it might take too long for clinical applicability, even with only 3 breath holds.
Got it. So there's the issue of only capturing right now one cardiac phase and only one slice at the same time. So if you wanted to capture multiple cardiac phases to see how these maps change throughout the cardiac cycle, you'd have to, again, repeat breath holds and then also over the volume of the heart. Okay, got it.
I know, for example, this is the case for dilated hypertrophic cardiomyopathy, where we need to see how much the heart dilates or contracts, and then we need the 2 phases, because one phase is not enough to tell anything about it.
Got it. And is there any way that you can use the information that you've collected potentially during one cardiac phase to help inform information in subsequent cardiac phases, like a joint denoising of that data in order to, for instance, allow you to get away with just one breath hold for the different cardiac phases?
Yeah, I think that's a great approach. We didn't have the data to do this for this specific paper because we asked some patients to stay a bit longer, or some volunteers to stay a bit longer to acquire this data over the years. So some data is a bit older, some data is a bit newer. So we don't have both phases for every patient, so this would have been a bit harder. But that's definitely a good idea because there's a lot of information that is shared between the two phases for sure, and between slices as well. Yeah, so 100%.
Awesome.
We also have a paper about showing how, for example, looking at all the slices at the same time improves results quite a lot. So that is also something.
Awesome. Okay, so we have a question from our chat from Rebecca Thornhill. She asks, could she ask what the computational complexity or demands were for this pipeline? Like what kind of computers you're using, how long the recon takes?
So is this question for training or inference? I imagine inference is the most likely answer, but if we can have a...
Let's do both.
Why not both? Training takes a lot of time. So training the model takes around, I don't remember specifically, it's definitely in the paper, something between 12 and 16 hours on the machine we had access to, which is a lot, but it only needs to be done once. And the machine we had access to was not super powerful, so doable. In terms of inference, it's actually quite fast. So I'm not sure it can be done at the scanner. It can be done at a scanner. I think it's quite fast, actually. I would imagine less than a second for a standard data set. I mean, I don't have numbers. This is just I've done it a couple of times. This is roughly what I have in mind.
All right, perfect. Are there any other questions from our audience? It seems a little quiet out there.
It is a complex technology, of course.
But again, I think it's very exciting.
Very interesting, yeah. Mm-hmm.
I mean, again, like diffusion is used everywhere else, and you know, for us to not be able to use it in the hardware, it provides a totally different source of information is very frustrating. So getting closer to it is super exciting.
Yeah, absolutely.
All right, if there are no further questions, oh, go ahead, Matthias.
What? No. I just wanted to basically toss you the ball so that you can talk about the next one, but the next one would fall on the SCMR, right?
Yes. So we did not schedule a journal club during the SCMR. That's that Wednesday, and so our journal club is actually going to be the week after that, which I believe is the 11th. That could be right. And we almost had some speakers locked down, but one of our speakers actually can't make that day. And so I think we're going to try to move those speakers to the first week of March. Matthias and I are working on that. And so I don't have a topic to announce yet, but I will be able to send something, I'm hoping, in the next couple of days. So stay tuned.
Okay. Thank you so much, also on my behalf, and thanks, Nicole, for jumping in today.
Of course, anytime.
Take care, everybody.
Hope to see you in Brazil.
Yep.
Bye.
Great. Bye-bye.